The work around suicide prevention is so extensive and wide-reaching that really nobody in our health system can say, I can't play a part. Everybody from the environmental specialist, the social worker, physical therapist, the clerk, the security professional, that all of us have a part to play in suicide risk. You can do all the education you want, you can do all the adaptations, but you need a process. The risk incurred epidemic that we've had in our country around youth suicide really requires children's hospitals to step to the plate.
Hi, everybody. I'm Heidi Baskfield, Executive Director of Speak Our Minds and the producer of the Speak Our Minds podcast. And this week we are featuring none other than Dr. Nasuh Malas, who is the Service Chief of Child Psychiatry at the University of Michigan and C.S. Mott Children's Hospital. And Dr. Malas, you're joining us because we're doing this whole body of work and feature on exciting efforts in Children's Hospital to prevent youth suicide. So thanks for being with us today. And let's go ahead and get started. Let's talk really in the space where all of the good things begin and happen and get built off of. And that's what feels like not a sexy subject, but an important one around the efficaciousness of good screening. So when we talk about suicide screening in hospitals, what does it mean for a screener to be efficacious rather than to just be in place?
Thank you, Heidi. It's a real honor to speak today and to have this really important conversation. And I am so excited that CHA is spotlighting this issue. It is such a critical issue in many children's hospitals, and pediatric health systems across the country are grappling with how to best support at-risk youth who may have suicide risk in their families. And one of the critical tools we have is to surface that screening. I think a lot of times our colleagues, families that come to our hospital, even the youth themselves, may not understand why we're asking questions about suicide if they're presenting for a fracture, maybe an ear infection or something completely unrelated. And I think a lot of what we are doing is starting a conversation. Many of the youth that we screen, we are actually not identifying risk, but it may be an opportunity to talk about warning signs, to talk about other related issues regarding mental health well-being or mental health concerns. Maybe the family knows somebody who is struggling with suicidal risk, and it's an opportunity to educate. In our system and other systems, a certain portion of youth do screen positive. And sometimes that's the first time that risk is actually surfaced.
Yeah.
And it really is an opportunity to save a life, frankly. And we've seen that time and time again in our children's hospital. In terms of the efficacy of suicide screening, the first thing is for systems to identify a tool that has been validated in the use in the hospital setting, ER setting for youth. It is important to train and educate staff, particularly those frontline staff that are going to be operationalizing those screenings. And then to have policy and protocol to identify how that process occurs so it's seamless and clear. One of the things that I think has been a big challenge across the country is ensuring the fidelity of the screening. So we want to screen in a way that really is conducive to sharing information and allowing youth that may be a bit nervous, concerned, worried to share. And so asking the question, you don't really have suicidal thoughts, do you? May not be a welcoming way to engage a child or a family. But knowing the right ways to, in a curious and empathic way, ask those questions in the way that they were intended, then help our partners on the front line know how to do that in a way that allows for that conversation and to identify that risk. And one of the things that we've done here, in addition to providing that training and providing that systematically throughout our system, is also to create some tip sheets and guides to troubleshoot those situations where a parent of a 12-year-old may not want to leave the room or, have their child screened because they might not understand the risk. How do we navigate that? How do we partner with families? How do we ensure that the screening is done confidentially? What devices may we use? Do we use a tablet? Do we use a paper form? And then, ultimately, and hopefully we'll talk about this a little bit, it's about tracking our outcomes. So understanding the data, what are we doing? How is it impacting care? And what happens after that screen? So really, it really takes team effort, requires a lot of training and education to provide something with high fidelity and do it consistently in a systematic way.
I think people are interested that hospitals, in particular children's hospitals, don't necessarily already do this, right? Like it is a significant commitment to implement a new screening process and tool. Can you just share briefly where you started and where all you're doing this screening now?
Yes. So the demands on our hospital staff are tremendous, whether it's sepsis, fall prevention. There's so many different hacks and processes and screenings and protocols that our teams have to manage. And I think what's most critical for us is the education piece. When we empower our frontline staff with awareness and understanding of why we're screening for suicide, what impact is suicide having on our communities, who are particularly vulnerable, what does screening do, and what happens after screening, it really empowers those frontline staff to feel like they are making a difference and not just checking a box. Additionally, providing tools. So that may be providing EMR, so electronic medical record tools that are embedded and easy to integrate. Being mindful of a busy social work or nursing workflow. If those are your frontline staff that are conducting the initial screens, how do we embed it in a way that feels seamless and not disruptive to other aspects of care that are critical? And then how do we empower those staff with layers of support? So we have a 24/7 psychiatry consultation service. We have psychologists with expertise in a variety of conditions, including suicide risk. We have social workers round the clock. We have a full team, as well as our providers that are providing physical health care, medical care, are heavily invested. And when you see that across the board, that the entire team not only is empowered and educated, but invested in the work and understands the mission, it makes it a lot easier to educate our youth and families when they come in, to take that pause, for 30 seconds to a minute to ask a few questions, to make sure we're not deferring or, quickly going through the process and providing a high fidelity screen. We had to really invest in that time to build that foundation. And then ultimately what we find is really helpful is you can do all the education you want, you can do all the adaptations, but you need a process. We all are process driven teams. And when that process is clearly outlined, it is embedded naturally into the workflow through order sets, through protocols, through policy. We can all have a standard workflow that we can reference and identify, and then that allows us to build resources on top of that. So we're also, when we developed a lot of these pathways years ago, it wasn't just one and done. It's a process of constantly reflecting, reviewing the data, gathering input from our frontline staff, and then innovating to improve our processes.
Sure. And all of that makes sense, right? Like how you bring people into the fold, how you provide them with the tools and the clear ability to engage in a well-constructed process is really important. And that really takes us to the next piece, which is like screening is only as strong as the referral that follows, right? Like why bother asking a question, right? Like we hear this from staff all the time. We don't want to ask these questions if we don't know what we're going to do with the information that comes out of asking those questions. So can you talk about like the process of the referral that follows once you identify different needs and what how do you create fidelity around a referral process? What will that require? I mean, as you're talking to some of your colleagues out there, what do they need to know about this?
So that's a great question because a lot of our staff even ask that what happens after a screen is positive. And in our hospital, roughly 8 to 10% of youth will screen positive at any given time. Sometimes that's historical risk, sometimes that's active risk. But again, it's always an opportunity for a conversation. It's always an opportunity to identify where the child's at in terms of their mental health and well being. And then in many of those cases, there are opportunities to help around that suicide risk. So we then conduct a risk assessment. And one of the things that we're working on currently is not only standardizing that risk assessment with a validated tool, but then embedding it into our medical records so that there's not heterogeneity and variability in terms of how we're conducting this assessment. The assessment that we provide on a Thursday midday should not be different than on a Sunday at 2 a.m.
Right.
There should be a really consistent pattern that we can educate to and can really anchor ourselves in the evidence so that when we're providing care, we're doing that consistently and equitably. Our social work staff are often doing those assessments. Sometimes it's our psychologists and psychiatrists. Many of those assessments also lead into conversations about issues like depression and self-injury, anxiety, ADHD, physical health, familial conflicts, school academic issues. But we do want to make sure that the core elements of a risk assessment are conducted. And then based on that risk assessment, we stratify that risk, determine what resources need to be deployed. And then oftentimes, if there is elevated risk, our psychiatry consultation team will provide that expertise and do a full assessment, oftentimes involving some recommendations and referrals. And then ultimately, anybody that presents with any level of risk gets a safety plan at a minimum. We also have started a post-discharge follow-up call process to check in with youth and families after they leave the hospital. And then we also have significant supports during the hospital stay because we do see every minute in the hospital as precious. And if that child or family is waiting for additional medical evaluation or potentially an inpatient psychiatric bed, we have workbooks and therapeutic activities that we can engage in with the family and the patient to support them throughout their stay.
That's amazing. And when you think, like, just listening to you, Nasu, about like all the work that comes from so many different team members and elements of the hospital that have to come together to make these processes work consistently, reliably, all of those things. It's pretty fascinating, and it's a lot of dedication. It also makes me think of just how much data comes up as a result of this process, right? Like piles and piles and piles of data. And one of the very cool things about CSMOT is the creation of a suicide care data dashboard. And so I think it would be great if you could talk about that dashboard. What goes into it? How do you utilize it? Like what is it about this that you really want people to know about and think about potentially replicating as they're also trying to think about how to better engage in the prevention of youth suicide?
You know, your question actually makes me think about when we first kind of took this journey and we were actually part of a 16 hospital collaborative supported by CHA and the Zero Suicide Institute and Cardinal Health to really look strategically and holistically throughout our system using that zero suicide framework and all of our processes and every single aspect of care to identify ways we can mitigate risk. And as we were going through that, we started to realize we didn't have much data. There was no line of sight to how many times we were screening, how many times we were assessing, just what was happening to youth during their care process. And one of the things that I think was really, really exciting for us was to be able to work with our data analytics team here to start to define what data we wanted, make sure it was feasible and sustainable to abstract, and then being able to look at it across multiple frameworks. So, if you're a younger child, suicide risk in younger youth under the age of 12 has been rising at an alarming rate. You can look at it by age. You can look at it by geographic area. You can look at it along a variety of different perspectives. You can look at data based on, are you presenting for a primary physical health concern or a primary mental health concern, and what's the screening rate, so that we can be able to articulate that. The fact that I could tell you earlier that we have 8 to 10% positive at any time of the year is because we were able to articulate that data through a data dashboard. The exciting thing about that is it highlights the collective need of our entire institution to work together on this. Because once you have the data, you can identify the areas of the system that are being affected. What's been really exciting is to really identify this work as a collective response, that it's everybody from the environmental specialist, the social worker, the physical therapist, across the board, the clerk, the security professional, that all of us have a part to play in suicide risk. And when people see how common suicide risk can be, when they can see the data, it really, again, just like screening strikes a conversation. Every time we present the data, there are so many questions.
Right.
What if this happens? How does that affect this? And why are we seeing this data trending one way or the other? So it's a really great way to educate our patients and families, to educate our systems leaders, improve our systems, but to also be curious about the why. Why are we seeing certain trends? Do we need to train to that? Do we need to change our processes? How can we improve the care experience? And I think it's been really exciting for people to see that, because the narratives are powerful. We certainly share the narratives, but when you have the data and you pair that with the narrative, it's really transformational. And on top of that, we haven't really talked about sustainability, but in terms of articulating the importance of this work to funders, wherever those funders may be, and we've been successful with getting some braided funding from multiple sources to sustain this work, you have to articulate the argument for this work and the importance of it, both through narrative and data. So in so many ways, it's been really powerful for us. We've been able to share this in reports with steering committee members and other key stakeholders. We've been able to share reports with our executive leaders in the Children's Hospital. And we've been able to articulate this to systems leaders to change how we provide care in a way that feels very tangible and meaningful for all those that are involved.
I love how data brings to life the evolution of practice that really results in these meaningful changes for families.
Yes.
And, that really transitions nicely into the next question around, I'm a parent, and I'm leaving the hospital after having been seen. And one of the issues that arises is the awareness that there is a potential risk of suicide with my child. I can't think of anything, very few things, that is quite so terrifying. And then to leave, right, a care setting,
Yes.
with that. Can you talk about like this post-discharge follow-up call and why that's important in this continued need to reduce risk? Like, how do you use that? How does that continue to support parents and their children?
I think you highlighted a very, very important aspect of this care, and that's the voice of individuals with lived experience. I think oftentimes we don't raise that voice enough and include that voice in the work we do. And as you stated, people don't come to the hospital or to the ER with suicide risk as if they're planning to go to a holiday or vacation. Their bags are not packed. They're coming in crisis. Things feel very disorienting, uncertain, and scary.
Yeah.
And so one of the things that's really, really important is to anchor families with a clear direction and a clear set of educational resources, opportunities for multiple communications with different members of the team, and a lot of clarity and transparency about what is happening, what is that risk, and how are we going to help you. And so that post-discharge follow-up call is something that both is evidence-based and is increasing in practice across the country. But it's the opportunity to connect and extend that relationship during probably one of the more higher risk periods, the transition out of the hospital back home with a child that has risk. One example that we often talk to families about is lethal means restriction.
Yes.
If you have a child that is cutting or maybe at risk of a suicide attempt, how do you store all those medications when you might have another child that has chronic medical issues at home, or an elderly, adult at home that you're supporting with chronic health issues where you need to access medications regularly? How do you store sharps when you're also trying to have dinner and do other things that require objects that are sharp? It's not enough to provide a handout. It's not enough to have a 2-minute conversation. It really is a process, and we have to kind of wrap our arms around that family and provide them ongoing support. So that contact, although it's not the end all be all, it provides an extension beyond the walls of the hospital to check in. And we've had situations where we've had to bring families back because they're in acute crisis, or the risk that was initially stable has escalated considerably because of a variety of factors.
Sure.
We've had many youth and many families who have felt very confident when they've left, and it's an opportunity to review the safety plan, to review the referral resources, to review questions that have come up. Universally, our families that we engage, and we've engaged several hundred in the past year, are really gracious for the opportunity to connect again. They rarely decline to be called. Beyond our program, several other programs across the country have taken it one step further and have used texting technology or other mobile or AI technology to create further caring contacts with youth and families to establish ongoing supportive messages, opportunities to share resources, educate on things like 988 and the use of that crisis line, and also just to kind of make sure families know we're here to help, that you're not alone in all this. We want to partner with you in identifying that risk, but if you start to feel unsure or unsafe in supporting your child once they've left, or the child themselves feel unsafe, that we are here. And we're doing that palpably through these caring contacts. I think it's been not only very beneficial for our families, but our staff just feel so happy that they can, through a brief call, really make a difference in that way. And we oftentimes in the hospital don't know what happens when folks leave. And this is a way to kind of feel assured that people are moving in the right direction, and those that maybe need more support can get that support.
Well, and sometimes families don't even know what questions they're going to have or what conditions they need support around in the moment of the time that they're leaving the hospital. So to have this level of support provided to them to allow them to have highly responsive care through that is really quite remarkable. I mean, I think about again, if I were a parent in a moment and what it would be that I would need, it is exactly these kinds of things. So I applaud you and your team for making those kinds of resources available to families and their kids, because ultimately it's the kids, that these parents and caregivers are ultimately trying to support. The other thing I want to talk about too is this engagement of community at large, right? So we're talking now about this community connection, or this caring connection with the discharge follow-up, but there's also this sort of like larger role that CSMOP plays in your community, and how you're engaging your community, and you've created a toolkit for your community. So can you talk about that toolkit, what it is, and what inspired its creation and how it's utilized?
Yeah, I think a big part of this work is recognizing the context that you're doing the work in. And just as much as we need to highlight and raise the voice of youth and family lived experience, it's the communities we serve. And it's important that this work is bidirectional, that we're really learning from our communities and adapting to their needs, but also partnering with them in this work. So, as part of our journey in addressing suicide prevention and suicide risk mitigation strategies at Mott, we've been developing resources, whether they be handouts, webinars, training series, things that nature, events that we have, newsletters, and we've been creating a repository to share that so that it's not only impacting those that come to our system, but that it may help other systems that are trying to do this work, other, community stakeholders or organizations that are also partnering in this work, that they can come to our site and learn and, sometimes even share or post their resources so that we can cross promote related activities. But the idea is to really not only leverage our expertise here to help those that are directly in our care, but to expand that to others in the state and in our region that could really benefit from the teachings, the resources, and the guidance. And in addition to our toolkit, we pair that with something called an engagement forum. So we have monthly learning sessions where we invite a speaker and go through about a 15-20 minute talk. Most of the time is really spent with facilitated discussion. So we have a moderator who has some questions, but really if the audience is eager to ask questions, we just let it go and have a conversation. We've also been blessed. We have a really strong research program here, a youth depression and suicide prevention program with a rich history. We've been able to partner with them, and they've done tremendous work nationally and internationally. And then we have faculty in our group that have developed partnerships with our Health and Human Services group in the state and have done rich work across the state to develop collaboratives and learning opportunities. I think we just are part of a very, very large team that is working fervently and eagerly to address this issue. And as we've learned more and more, this issue touches so many different people. We've learned a lot about our firearm injury prevention services in the state and locally. We've learned about other mental health initiatives that interface very closely, school-based initiatives. So I think we just need to be eager to be out there, to meet stakeholders. When folks come to our events, sometimes we meet with them to learn more about what their organizations are doing so we can partner in different ways. So it's been really exciting. I think this toolkit has been a platform for a lot of networking and collaboration. And like I said before, the work around suicide prevention is so extensive and wide reaching that really nobody in our health system can say, I can't play a part. And some of the most amazing stories we've heard here is a clerk or an administrator or a non-clinician knowing something was off and asking the question, are you okay? We've had situations like that where suicide risk has surfaced and we've been able to get people help. But it really is not just something psychiatrists do or psychologists do, but it's really a community-based effort, a collective effort. And as much as we can kind of raise all boats, we try to do that.
It's phenomenal. And I hope as people are listening to this, that they're really understanding and connecting with what an opportunity it is when you get to partner with community and how much stronger it makes both what you're able to do within a hospital context, but then that larger, broader network that is 100% required to support these kids and families once they leave.
Well, and I think that community work really requires a certain level of humility in what we do. I think sometimes we don't realize how privileged we are, with the resources we have in an academic institution like this. But putting yourself out there like that, it really allows for people to engage with you in a different way. And we've learned a lot, we've adapted, and we've had to be really flexible. And I think it's been a really lovely experience to be able to hear such wide perspectives, to be able to learn so much of, from families, from community members about what it's like to receive the care or experience a mental health crisis. And I think for us, we've just grown tremendously. And what I would say, when we started this journey, we thought we were doing a great job. And I think we are doing a tremendous job. But what was most eye-opening when we started was how much we could still be doing. And I think what was really neat about this is, anytime in medicine when there's a lot of work to do, sometimes it can be, it can be tough because there are a lot of demands. People have really stepped up. I cannot say enough that as we've been able to identify, well, we got more work to do,
Sure.
people are just signing up.
Endless.
Our most fervent advocates for this work are our emergency room nurses.
I would imagine.
Some of the busiest people, they are the biggest advocates for this work. So I think it's just been really humbling to be in a position to help guide some of this work. And it's a cliche, but it's very true. It really does take a village to address a lot of these issues.
Yes. Well, and that leads us to the next thing, which is like, this is a lot of work. It takes a lot of people coming to the table, and people got to get paid to do the work. So, can you talk a little bit about how these efforts are currently being supported financially and what other colleagues need to be thinking about by way of potentially creative problem solving in financial models to sustain things?
Yeah, that is a critical question that I think all of us are grappling with all the time, not only for this work, but other work that we do. And I think fundamentally it starts with a commitment to this being a necessary and inherent part of pediatric care. The risk incurred and the epidemic that we've had in our country around youth suicide really requires children's hospitals to step to the plate and step to the forefront of this work and be able to partner with everybody in the mental health community and in the community at large to really address this issue. So I think fundamentally it has to be value-based and mission-driven. But in addition to that, obviously you need to have a sustainability plan. And for any good sustainability plan, you need to not be suspect to one particular funding stream. So what we found is really a recipe for success is a kind of multi-pronged approach where we have upgraded funding streams. So we have some of our mental health supports supported by hospital operations. We are constantly looking for good partners and grant opportunities. One of the really neat activities at the University of Michigan, we have a philanthropic group called the Dance Marathon Group that raises money through dancing, which is really neat. I mean, they do a lot more than dancing. They're very community engaged. They do a lot of volunteer work. They have partnered with us and supported this work as well, which has been really lovely to see because, campus mental health, campus suicide risk is another important issue. Finding those community partners, finding those funders, grant funders that really want to support this work and being thoughtful about constantly seeking out that support. Some of this is also billable, and we are actually working through exploring that and identifying that. But, part of what we also have said as an institution is this is just essential work. So regardless of billing or not, I know different institutions do explore billing for services. We've just determined this is essential work that we have to do because it's what we have to do and it's how we really help support youth and families at risk. And then lastly, I will say that philanthropy has been another source of support. A lot of families that we care for come to us and tell us, hey, we want to help in some way. We have a team here that facilitates those conversations, helps support our care teams because we sometimes feel awkward in those situations because we don't want to necessarily talk about that. But how can we really create a conduit or an avenue for a grateful family to give back, to support this work? And we've had fundraisers specifically to both create awareness and generate funding but also folks are given throughout the year because they really see the importance of this work. And ultimately, through those various funding streams, we've been able to support this work now for 4 years as a institution that's adopted the zero suicide framework, but several years prior to that through these different funding streams.
Yeah, that's so helpful to be able to highlight. And as we close things out, what's the one piece of advice? I know there's like lots of advice you could give, right? This whole episode is really providing people with great information. But if there's one piece of advice to hospital leaders who want to strengthen their suicide screening as a core part of prevention, what would it be?
So there was one question that was raised to our group and other groups in that initial 16 hospital collaborative through CHA and the Zero Suicide Institute supported by Cardinal Health. And that question was, how many youth suicides are acceptable in your health system? And I think when we think about that, we've used that question before because I think it's a very powerful and jarring question to ask. It's really none. And so what can we do to get as close to zero as we can? We know suicide is a very complex issue. There are a lot of factors that contribute to it, but recognizing that we can save lives with this work, and we can not only save lives, but also impact families and communities in a way that is transformational. So my piece of advice to provide folks that are hoping to implement this or grow their work around suicide prevention is to really be patient and to lean into this work. What we are doing now was not happening yesterday or the day before or the day before that. The work can feel daunting. It can be complex. It can be highly multifaceted. It can take a long time to change processes or the medical record, or to break through certain cultures or certain barriers. But again, the work we do makes a difference. Even saving one life is worth every single second, minute, and hour that we spend in this work, and just being patient, knowing that as we continue to work together on this, that every single movement we make forward is something that didn't exist before. And ultimately, our goal is to save lives and to make lives of kids and families better. And I think by doing that and staying true to that mission, we have had ups and downs in our process, but we've been able to see a lot of success and a lot of rallying around this work that I think, if you asked me 4 years ago, I don't think I would have expected we'd be at this point. So just being patient and sticking to that mission.
Dr. Nasuh Malas, I cannot thank you and your team enough as a mom. When I think about the one life worth saving, if that, like to have that amount of commitment and dedication has a powerful impact on your community. So a huge thank you to you, your team at CS Mont Children's University of Michigan. And we'll be excited because I want to keep talking to you about this in future episodes, right? Because the work you're doing is going to continue to grow and evolve, and your leadership in this space, people are going to want to hear more and learn more from what you're learning. So thanks for joining us, and we'll look forward to the future episodes together.
Yeah, thank you. And I look forward to continuing the conversation. Really appreciate it.
Thanks.